Brian.
Hello, everyone. Welcome, welcome. We're getting started now. My name is Brian Harrison. It is my honor to be part of the Osher Lifelong Learning Institute at Berkshire Community College, or OLLI. For those who are new to OLLI, we provide exciting educational, social, and volunteering opportunities designed especially by and for people 50 years and better, but open to everyone. We're one of 120 OLLIs around the country, all with similar mission, and each OLLI is associated with a different college, from Berkeley to Duke to Berkshire Community College. We have members of other OLLIs on the webinar joining us today, in addition to our own, as well as members of the community. Not only do we offer special events like today's, we also offer 5 semesters of classes in science, history, art, literature, and social sciences, with no tests, no grades, just learning for the sake of learning. You can find out more about our classes on our website at berkshireolli.org. We are in the middle of the winter semester, and the spring semester starts on March 22nd. This event today, entitled Healthcare Does Not Equal Health, Drivers of Health Inequities for Older Adults, is the second of 4 educational events that grew out of our shared interest group called Changing the Culture of Aging, which in turn grew out of the University Day on Ageism held in August 2019. I want to acknowledge the contributions of all the members of our shared interest group: Fran Weinberg, Mary Jane Incorvia, Kate Kidd, Patty Janchuk, Laura Kittross, and Megan Wilden, in addition to myself. We have spent over a year in bi-weekly meetings talking about how our group can contribute to improved healthcare delivery in our community. When we decided that we would offer a series of presentations, the first one on January 6th focused on age-friendly health systems, and today's being the second, we knew that these issues will have ramifications beyond Berkshire County. We're very interested in learning what we can do to help improve healthcare in the Berkshires and beyond. This event is being presented in webinar format, which means you have all been muted and your video is turned off, so we can't hear or see you. Questions can be submitted in the chat, and Kate Kidd, our moderator, will choose from among as many questions as she can, given the time limit of 90 minutes for this event. And now it is my privilege to turn this over to Mary Jane Incorvia for an introduction to today's speaker.
Thank you, Brian. I am Mary Jane Incorvia Mattina, one of the co-founders of Berkshire Supergenarians, and I want to start, of course, with several thank yous. First, to OLLI at BCC for again partnering with us to bring this wonderful series of talks to you on healthcare for older adults. And we are really delighted that OLLI has agreed to do this and to open it up to the community at large. I also want to thank the other members of our shared interest group. We've been working together for over a year in very frank and forthright conversations, first face-to-face and then on Zoom meetings. And I think we hopefully have made a nice contribution to our region and then beyond that with this series of presentations. I want to thank our sponsors for making our publicity possible for this series: October Mountain Financial, Greylock Federal Credit Union, Lee Bank, and the Robert C. and Tina Son Foundation. We are so delighted to bring this very important topic of health inequities into this forum because we think it's very timely and it's also very, very important. I'm also very grateful to Dr. Lena Makaroun for taking some time from her personal and professional lives to speak with us today. And you may also be interested in knowing that Dr. Makaroun did an interview on WAMC radio, which I'm sure you'll be able to find online. It's very informative as well. Dr. Makaroun is a geriatrician and a health services researcher at the Veterans Administration Pittsburgh Center for Health Equity Research and Promotion. She is also an assistant professor of medicine at the University of Pittsburgh School of Medicine. She got her undergraduate degree at the University of Pennsylvania, her MD at Weill Cornell Medical College, and her MS in Health Services at the University of Washington School of Public Health. She did a 3-year VA Advanced Postdoctoral Fellowship in Health Services Research, and then she joined the University of Pittsburgh in 2019. She is the youngest ever member of the Board of Directors of the American Geriatric Society, where she is co-chairing their initiative to address the intersection of structural racism and ageism. And she is also a mother. And I am very, very grateful to Dr. Maura Brennan for putting us on the road to contacting Dr. Makaroun for her to speak today. Thank you, Dr. Makaroun, and the screen is yours.
Fantastic. Well, thank you for that introduction. And before I get started, I also would just like to thank the Osher Lifelong Learning Institute, the Berkshire Supergenarians and Age-Friendly Berkshires for inviting me. It's really a pleasure to get to spend the next 90 minutes or so with all of you attending from, I was reading on the chat, as far away as California, Oregon, Washington, you know, and all across the country. So it's really nice to have such a diverse array of people joining us today geographically. So the content of today's talk is pretty ambitious in terms of what we're hoping to kind of gain together a better understanding of. You know, I am targeting this talk towards people who I'm going to assume have, you know, maybe only a very basic understanding of some of these issues, or maybe haven't even spent much time thinking about this at all, and you're kind of here as a first exposure. And so I developed this talk to intend it to be kind of for a really broad audience, and I hope we're all going to come away with it from it with a better understanding of what contributes to health inequities for older adults, but also what contributes to these health inequities for adults of all ages. So first, I'll just say that I have no relevant conflicts of interest to disclose financially, except that I, too, one day do hope to grow old, or I like, as it was put, to become 50 or better. And so obviously, I also have a vested interest in these issues, as I think we all do. So this is how we're going to spend our time together. I always think it's helpful to have a little roadmap. I think that a lot of the stimulus for wanting to hear about this topic came from the COVID-19 pandemic and a lot of the things we've seen come to light during this past year, especially and perhaps more so for older adults. But we really can't get to talking about health disparities or really understanding health disparities without understanding the social determinants of health. So first, we're going to kind of just outline some basics about health disparities in older adults, but we're going to take a deeper dive into social determinants of health, as well as healthcare system bias and how those things may contribute to these disparities we see for adults as they get into the later stages of life. And then we will spend some time at the end talking about this in the context of COVID-19, especially with some discussion about vaccine rollout. And I want to just add before we get started that this talk is mostly going to focus on racial and ethnic disparities, though of course disparities exist across many other overlapping lines such as socioeconomic status, LGBTQ status, and immigration status, just to name a few. So this talk will focus on racial and ethnic disparities, but you know, there are lots of disparities that we could be talking about here, but I think that a lot of them actually will kind of be highlighted by discussing racial and ethnic disparities for older adults. And then I'm planning to leave a good chunk of time at the end for questions. So don't hesitate to put stuff in the chat as we go, and hopefully we'll have time to address as many as possible at the end. All right, so let's get started then. So over the past century, with the exception actually of just the past few years, where we've seen a slight decline in life expectancy, mostly due to things like drug overdose with the opioid epidemic, we've actually enjoyed in this country lengthening life expectancy. But for older adults in particular, I think we have the perspective that actually it's not just about how long we live, but it's about how well do we live and what's our quality of life in those later years. And so we really like to think about what we call healthy life expectancy, or years lived without disability. And if you think about when you reach age 65, how many years of healthy life expectancy you might expect if you make it that far, how many more years could you expect to live? We see that there are really drastic differences between white and Black people in America. So this map will show you, on the left is representing white people and on the right is representing Black people. And blue color is indicating longer years. So the darkest blue is more than 15 years of healthy life expectancy at age 65. And the more white it gets, the lower the years. And so you'll just visually, you can see that Black Americans have much lower healthy life expectancy if they are lucky enough to reach age 65 compared to white Americans. And though these data are a little bit old, so these are from the CDC from about 10 years ago, the same patterns are seen today. So even though the population as a whole has enjoyed lengthened life expectancy, this has not been equally enjoyed by all segments of the population. And when we think about why might this be, we see that a lot of the chronic medical conditions that may contribute to early mortality or mortality in general are also unequally distributed amongst Black and white Americans. So compared to white adults, Black adults at each age group, so in case it's too small to see, we're looking at the top bar here, and each section of bars is representing an increasing age category. So first 18 to 34, then 35 to 49, and then 50 to 64. So leading us up to that age 65, that we showed on the prior slide, you can see that a higher proportion of Black Americans have high blood pressure, diabetes, and stroke, all of which are major contributors to early morbidity and mortality for older adults. And when you then look at the bottom graph, which is demonstrating deaths from any cause, so not just those cardiovascular medical problems at the top, but any cause, you can see again at each of these age categories. So even in the younger age groups, 18 to 34, 35 to 49, and 50 to 64, Black adults in the US are dying more than white adults. So, from the last slide and this slide, we can see that Black Americans are experiencing a higher burden of chronic medical conditions across the age spectrum and dying more than white adults across the age spectrum leading up to older age at age 65. And then those who are, who make it to age 65 are also less likely to have, the longer healthy life expectancy at that age. The other thing that we really care about here is that these cardiovascular medical problems are also what contribute to one of the things that, at least for my patients, is one of the most feared outcomes of older age, which is dementia. So if we look at the distribution of dementia in older adults, so here the age categories we're looking at are 55 and above, all the way up to, on the right, we have 85 plus. The blue bars are representing Black, red bars are Hispanic, and white, and the green bars are white. You can see again at each age category, Black Americans are more likely than Hispanic, and Hispanic are more likely than white to have dementia in middle and older ages. And again, a big part of this can be attributed to the higher proportion of these medical problems that we know contribute to the development of different kinds of dementia. But in addition to that, there may be other things that are driving this. We also know that dementia, the development of dementia, is tied to things that maybe we don't classically think about as medical, but things like high quality education earlier in life, and that these things may be unequally distributed amongst different races in the US. And so over the past few slides, I've shown you that, um, you know, Black people in America have more medical problems, die at younger ages, and older adults have more dementia than their white counterparts. And so you may be wondering at this point, okay, well, why is that? What is it that makes Black people so different that they're having these issues? And does it have to do with race? Um, so this is, part of this talk is going to be about debunking some myths, and really unraveling certain, thought processes and patterns that many of us may have held for a really long time in our lives. And the first myth that I think we really need to unravel is the race myth. So for many centuries, race has been posited as a biological reality to justify and support, really the subjugation of people of color in this country. And this dates back all the way to the time of slavery, when it really was beneficial to white slave owners and the whole system of slavery to suggest and put forward that, Black people were different. There was something biologically different about them that made slavery okay, that made them more tolerant to the work stress, and could justify the horrors of slavery. But that myth kind of perpetuated and continued on far after slavery ended. And despite the fact that science has disproven this many, many, many times now, people have, and what I mean by that is that if we look at genetically, what makes people, if we compare people in one race to each other, or compare people of different races to each other, people within a race may be genetically more different than people from different races. And really, there is no genetic or biologic reality to race beyond, a gene that determines your skin pigmentation. So the idea that there is a biologic driver for all of these disparities that we're seeing, I think can really be dismissed as not true. And anything that kind of tries to posit race as the explanation for these differences, I think has to be challenged really strongly, because it's dangerous to continue thinking that way. So in fact, what is race then if it's not a biological reality? Race is really a social construct. So like I mentioned, the way that race kind of really was defined in this country has its roots in slavery. And the disparities that we see that are race related really have to do with the social constructs that we have created over time related to race, and the ways in which those social constructs have then embedded themselves in our systems, in our institutions, and in our structures of power, that have impacted people in many different ways. And we're going to talk about that in a lot more detail over the next few slides. So to dig even deeper into this, there's another myth that we have to uncover, which is that healthcare and health can be equated with each other. So it turns out, we like to think that if you have access to great healthcare and great treatments and all the right pills and all the right tests, then you're going to be healthy. And it turns out that that's just not true. Healthcare accounts for only a very small proportion of what makes individuals and populations healthy and provides quality of life and well-being. And in fact, if you look at what is the major driver, it's actually social, environmental, and behavioral factors. So looking at this breakdown, if we think about genetics, if we think about healthcare, and we think about this bigger chunk of, the social factors, there's nothing much, at least now, that we can do about genetics, although that's probably changing. We have lots of genetic therapeutics that are coming, but for this talk, we'll assume that there's nothing much we can do about genetics. We will talk about healthcare a little later, but because the biggest component contributing to health are actually social risk factors, also known as, and I'll refer to those in this talk as social determinants of health, it can't be stressed enough that this is actually where a lot of our attention should go when we're thinking about what is driving inequities in healthcare for our population, and especially for our older adults. So what exactly are social determinants of health? So according to the Center for Medicare and Medicaid Services, social determinants of health refer to the range of social, environmental, and economic factors that can influence health status. Conditions that can often have a greater impact on health outcomes than the actual delivery of health services. So I like to kind of simplify this into, asking some really just key basic questions, almost the type of questions that you would ask someone if you met them in a coffee shop or on the subway and we're just trying to get to know them. So, where do you live? Where do you learn? Where do you work? Where you age? Socioeconomic status, race. These are the things that make up the social determinants of health and that are really critical towards contributing to health outcomes. So let's take just a little bit more detailed look at what that really means. So in this table here, in the top heading, you'll see some big categories of different social factors that contribute to health. And we'll go through one by one and just think about a few examples, because I think that it can help us to think about in our own lives, how have these things either advantaged us and helped contribute to good health and good function and well-being, or how have some of these things maybe disadvantaged us? So thinking about economic stability first. Employment. So what kind of jobs did you have access to? And it's not just do you have a job or do you not have a job, but is the industry in which you work one in which you can have sick days or flexible time off when you need it? Or benefits that come along with your job? Or do you potentially work in an industry where it's mostly part-time work without benefits? Income obviously significantly contributes to economic stability, but it's not just income, but also what kind of expenses and debt did you inherit? What's your family structure? Who else are you supporting? And do you have a safety net? So I think, when we think about economic stability and differences between different people in our country, do you have a family or do you come from a community in which there's a safety net of people you can rely on if you fall on hard economic times? Do you have parents who can bail you out if you're in debt, or if you lose your job and you need help for a couple months paying rent? Or do you really not have anyone to rely on? All of these things can contribute to your economic stability and can contribute to how you're able to also spend money on healthy behaviors, the stress you may experience, and also the healthcare access you may have. Moving on to the next column, if we think about neighborhood and physical environment, these things are really important. So housing, number one, I think that this has really been called to light during COVID, as there's been huge problems with people not being able to pay their rent. And thankfully, we've had some federal relief in terms of eviction moratoriums, but that can only go so far. And I think we realize that stable housing is so critical to people's health and well-being. And home ownership versus renting versus what allows you to buy a home. Do you have access to a good rate on a mortgage? We know that there are different practices with who gets mortgages and who doesn't from the banks, with Black Americans being less likely to be able to get mortgages. Transportation. Do you live somewhere with easy, accessible, reliable public transportation? Do you have access to a car? Again, these things make a huge difference in terms of the childcare you can access, the jobs that you can access. Not on this list, but also very important, are environmental exposures. So air pollutants, et cetera. This is really important in my area where we, down south from here in the Monongahela Valley have steel mills still. We saw this obviously in Flint, Michigan, with lead exposure and other exposures in water. So these things are really critical to public health and to individual health as well. Education, this is one that probably is one of the most important, but also um, gets the least attention and probably suffers from some of the biggest issues in terms of underfunding and under prioritization. But education really, especially early in life, leads to so many downstream opportunities, and like I mentioned before, has been tied to actually high quality early education has been tied to decreased risk of developing dementia later in life. But literacy, what language do you speak? Are you a primary English speaker or not? Higher access to higher education, which again may be linked to economic stability. So I think you'll also see that a lot of these are intertwined and not really, just separate columns the way they're presented here. But education can really determine many things that impact your health down the line, above and beyond just health literacy. Food. So I think we can all appreciate that access to healthy food is really critical for maintaining health, but food security can look very different depending on what challenges you're facing. So it may not be that you just don't have adequate calories, but maybe the calories you have access to are just not the kind that are nutritious, or going to prevent those chronic diseases. So you may live in a food desert where, the corner store is the closest and easiest and cheapest option for you, but doesn't carry fresh produce, or easy to make meals for your family if you're working, without additional help and need to put something on the table quick at night. Community and social context. This is also critically important for older adults. Having social integration and supported systems and a community and social network that can provide resources, support, prevent isolation, decrease stress. These are all really critical things for well-being and health. And then you'll see finally, after all of this, we finally get to the healthcare system, which again, here we're not talking about, when we think about the healthcare system as a social determinant of health, we're not thinking about medical treatments or, did we develop the right medicine or pill or surgery for the problem you have? What we're really thinking about is access. So even given that the treatments for what you may have exist, do you have access to them? Can you afford them? Do you live in an area where the providers are well trained and provide good quality care? Do you have insurance? Can you pay for it? Can you take time off work to go and see your primary care doctor when you need to? So all of these things are really critical, and consider them also a social determinant of health, which is the access that you have to the healthcare system. So maybe we have a world-class, amazing healthcare system in the United States, but if you don't have access to it, it doesn't really help you much. So I think you can see how all of these things can contribute to the health outcomes that we care about, namely mortality, morbidity, life expectancy, also costs. But in older age, some of the things we care about more: functional limitations, cognitive limitations, quality of life, well-being, the ability to be engaged in your community, to continue doing meaningful tasks. All of these things can be impacted by social determinants of health. And then one thing that is weaving through all of these, especially as experienced by people of color in this country, is racism and discrimination. When we, as I touched on all of these issues and kind of the varying ways in which people may experience these different social factors, a lot of it is influenced by structural racism. And so I want to spend some time here because I think that this is a term and a topic that has come up more frequently lately, in public press and in the media, because of what we've seen with COVID and because of many high-profile killings of Black Americans, including George Floyd, Breonna Taylor, Ahmaud Arbery. But systemic racism and structural racism has been a part of our country since America was founded, as we've kind of already touched on a little bit. So let's take a moment trying to really understand what this is and how does it actually link up or tie to health disparities. So all of the different social determinants that we discussed, what neighborhood you live in, what kind of employment you may have access to, your transportation, your housing opportunities, all of these things are set up in systems and structures that are influenced by people in power in this country that have weaved into them systemic racism, and that treats people of different colors and from different walks of life differently in a way that systematically discriminates against and disempowers and oppresses people of color compared to white people. And so just to give a few examples of how this might manifest. We have a long history of neighborhood discrimination and segregation in this country, with, poorer Black neighborhoods potentially having worse access to grocery stores, worse access to parks, more environmental pollutants, lower quality schools based on how our school systems are funded by property taxes in this country. Another example would be job opportunities. So there have been studies showing that even for two equally qualified candidates, the candidate who has a Black sounding name is less likely to get the interview for the job or get the job than the person with the white sounding name. So we know that there is profound discrimination and bias in terms of who gets jobs in this country. And you can see that really clearly when you just look at the proportion of Black versus white people in certain professions in this country. So that really leads also to, different economic opportunities. Those are just a few examples, but understanding the way that structural racism influences the social determinants of health and how the social determinants of health are really the main drivers of health, not only in this country, but around the world, we can start to see how there may be these major disparities in health for older adults from racial and ethnic minority groups. Furthermore, if you think about what it's like to live a life experiencing these types of micro and macro aggressions. So what I mean by that is when we say macroaggressions, so things that are really overt, signs of racism, versus microaggressions, which are maybe potentially less intentional, but just as harmful. Living through a lifetime of that can cause chronic stress, that really contributes to a lot of these chronic medical problems that we already highlighted are disproportionately experienced by people of color. And so when we think about all of this, especially for older adults, it's really important to think about not just the older adult in front of you and at that point in their life, but to really take a life course approach and to think about the whole life cycle. So what has this person lived through to get to where they are now? All the way from the time of conception, when, what was the health and experience and challenges that this patient's mother faced? What was their infancy like? What was their childhood like? What were the challenges they faced at each of these steps? All of these things contribute to the health, well-being, and quality of life in older age. So more so than adults or children at different stages in the life spectrum, older adults, we really have to think about this entire arc, because things really stick with you and can create a cumulative disadvantage over time that is very hard to undo, quite frankly, just by kind of providing good medical care at the end of life, right? So in the US, unfortunately, that's generally where we put our focus. Is we think, okay, there's someone who has this health problem, let's give it a pill, let's give it, the right treatment, and we'll fix everything. But the reality is, if the way that person got there is stemming from a lived experience of chronic stress from racism, chronic disadvantage due to lots of social determinants, it's you need to do a lot more to try to undo that type of damage, and looking forward to try to prevent that type of damage from other people in the population. And this was shown recently. There was a paper that just came out recently looking at 11 different high income countries, including the United States, and income related inequality in affordability and access to primary care. The authors stated that in their conclusions that only in the US were there consistently wide income disparities on all measures related to accessible primary care. And despite spending more on healthcare than any other developed country, we do consistently see that the US has worse health outcomes. And again, I think one way of framing this is thinking about the fact that, thinking about that healthcare only accounts for 20% of health. And so even though we're spending a lot in that bucket, we're not going to make a big dent unless we spend a lot in the other buckets. And in fact, the authors state this, that in the US, for every dollar spent on healthcare, another $1 is spent on social services. When you compare that to the other countries in this study, for every dollar they spend on healthcare, an additional $2.50 is spent on social services. So we see that most other developed countries are spending 2.5 times more, relatively speaking, than the US on these social risk factors, and that the US is really systematically underinvesting in addressing the social determinants of health. And when you think about this underinvestment really across the life course and how that leads to accumulated disadvantage for high-risk groups, the reality is, though, it really does a disservice to us all, even though it's disproportionately impacting people who are at especially high risk, such as groups from racial and ethnic minorities. So we've talked about social determinants of health and how they contribute to health disparities. But, the healthcare system does matter. And, the healthcare system is also not perfect. In fact, far from perfect. So it's not like all these problems exist, but, once someone is 65 and gets their Medicare and has, access to health insurance coverage and presumably can, go to the doctor whenever they want, everything is going to be hunky-dory. Unfortunately, our healthcare system is also fraught with a long history of racism and malpractice. So many people may have heard of the Tuskegee syphilis study that took place between the 30s and 70s, where Black men were followed with syphilis and not treated to see the natural course of disease, which is, of course, horribly unethical. But we also have, that's just one of many, many examples. So the pictures on this slide demonstrate, just a few of those things. So we have a long history earlier in American history of forced sterilization of women of color. Dr. Marion Sims, who's considered the father of gynecology, actually did many of his studies and developments on experimentation on women held in slavery who could not provide consent or could not refuse consent to participate in studies. And he continues to this day to have many things, instruments, and other things named after him. So the legacy, unfortunately, continues to live on. Up until disturbingly recently, hospitals in this country were segregated. There was discrimination in who could become a doctor. And even though there's not overt discrimination now or overt policies in terms of who can and can't become a doctor, physicians are still, Black people are still incredibly underrepresented amongst physicians and other healthcare professionals. likely due to many of these kind of upstream effects of systemic racism that we've already talked about. So these things are just some examples that are kind of striking, but they're really just the tip of the iceberg. Because even now in modern day medicine, we know that Black patients continue to experience forms of discrimination. So in this study where over 2,000 US adults were surveyed, 21%, so over 1 in 5 adults had experienced discrimination in the healthcare system. And of the people who experienced discrimination, the vast majority of those experienced racial and ethnic discrimination. That was the most common type. We also know that there are disparities in the types of treatment and the diagnoses that people get. So many studies have shown that Black patients do not get equal care, and much of this may be explained by provider biases. So these are just some examples, but we know that Black women experience over 3 times higher maternal mortality than white women in the US, and they are less likely to get early prenatal care. And I didn't put this on the slide, but also they're more likely to be born premature, which can have downstream consequences for health and well-being of that child. A study done in 2015 showed that Black children with appendicitis compared to white children were 80% less likely to receive opioids for pain. So, children of 2 different races presenting with the same problem, appendicitis, and you see an 80% difference in the likelihood to have their pain taken seriously and compassionately treated with the evidence-based treatment, which is, pain medication to control that pain. And these are children. A really kind of shocking study done in 2016 of medical students and residents showed that some white medical students and residents believe Black people's nerve endings are less sensitive than white people's. And this is also particularly disturbing because you can imagine how it directly would tie to differences in prescribing medication or to treat pain or to take pain seriously. And this is actually very similar to the type of justification that I referenced earlier in the talk related to slavery and how these myths about racial differences in pain tolerance, for example, were put forward to explain and justify why Black people were particularly suited to hard labor, for example. So it's really disturbing to see these types of thoughts continue to pervade even within our trainees and medical community. And in that same study, 40% of first and second year med students thought Black people's skin was thicker than white people's. Again, also really disturbing given the history of those types of thoughts. So these are just a few examples, but there are many, many examples in the medical literature. And as I showed in the last study, people's own experience, their lived experiences that they experience, that this is true, and that when they go to see the doctor, this is real for them. So understanding the ways the systemic racism impact the social determinants of health and how the healthcare system itself provide biased and discriminatory care at times, we can now better understand how older adults of color experience worse health outcomes. So the American Psychological Association has this really nice brief about this that I pulled from a little bit, but thinking about aging while Black in America and then combining that with, the life cycle and life course approach that I presented to you earlier, if you think about that all Black people in the US, both young and old, have experienced racial discrimination throughout their life. But now you just think about the cumulative years of life lived for an older Black American. Black older adults have experienced cumulative race-related stressors over a lifetime that negatively impact their physical and mental health in older age. But in addition to kind of living while Black and aging while Black in America, it's also not easy to age in America, period, because the other thing that all people aging in America have to face is another ism, which is ageism. So the other thing I think is very important to understand when we're thinking about this particular population is how ageism and racism really interact. And the term intersectionality is one, again, that is kind of been maybe thrown around, or maybe you've heard of more in the past year than you might have beforehand. But really, it's the idea that two forms of maybe bias or discrimination, if experienced, are greater than the sum of their parts. So it's not just that you experience ageism, you experience racism, and those two things are distinct, but in fact, living as an older Black person or living as an older Black woman and experiencing sexism too, that these things combine to have a cumulative effect that may be greater and unique than the sum of its parts. And we know that in this country, ageism is really prevalent. And one of my mentors and the Dean of Medicine at USC, Dr. Laura Mosqueda, has a quote that I always like to remember, which is that ageism is the only ism we will all face if we're lucky enough, right? So if we're lucky enough to get old, unfortunately, we will also face ageism in this country, where older adults can face certain stereotypes that devalues them, and sometimes even dehumanizes and marginalizes them. And particularly, this may be true of certain groups, like those in nursing homes, for example. Certainly intersectionality does not just get restricted to, ageism and racism. So we see lots of other characteristics that may condone other vulnerabilities for older adults. So just thinking about one other one, which is LGBTQ status. So there are 2.7 million adults who identify as LGBTQ who are 50 and older in the United States, and approximately 1 in 5 of those are people of color. So again, thinking about what that experience is to be Black and experience systemic racism, but also to be, of a gender or sexual orientation minority and experience discrimination based on that, potentially more so earlier in life when, society was not as accepting of that. And then to be facing ageism and a lot of the challenges that come along with aging, you can see how these things can all kind of meet to make a perfect storm. And so I think that intersectionality is a great segue actually into thinking about COVID. And this is kind of the final portion of this talk, where, the COVID pandemic has not created new problems in society that weren't there before, but gosh, has it really surfaced things that have been there and have managed to stay out of the public eye. What we've seen in the most simplistic terms in the COVID-19 pandemic is that older people have been affected most, and particularly those in nursing homes, and then people of color. So Black, Latinx, and Native people have been disproportionately struck and harmed by this pandemic. So just to put a few numbers to that, so looking at COVID-19 related racial and ethnic disparities compared to whites, Blacks are 3.3 times more likely to be hospitalized and almost 2.5 times more likely to die from COVID-19 compared to whites. Hispanics are a little over 4 times more likely to be hospitalized, and again, almost 2.5 times more likely to die. And Asians are 2.1 times more likely to be hospitalized and 1.9 times more likely to die from COVID-19. So again, we have to ask ourselves, why is this? And, I hope at this point in the talk, and I hope moving forward, you will resist the urge to think that this is because of some sort of biological difference between these groups and white people. Remember, there is no biological race. So the differences we're seeing are the result of the vestiges of ongoing inequitable systems and practices. So we've really seen ageism and structural racism come to light during COVID because the spotlight has been on, older adults and people of color who've been bearing the brunt of this. So I think, the great news is, of course, we have vaccines coming. They are here, more are coming. We're doing our best to get them out. But it's really important that we keep these issues in mind as we are distributing vaccines. As this editorial that just came out last week put really nicely, as we've started, many states now are vaccinating people 65 and older. But Dr. Bachner writes, however, if this approach is adopted without explicit attention to promoting health equity, it will once again exacerbate major health disparities. Why? Because in most cases thus far, the process of making an appointment to be vaccinated requires substantial time, technology, and trust, three resources that are unequally distributed in much of the US population. So let's talk a little bit more about that, the resources and the trust. So in the vaccine rollout, it's still in the early stages in some degree, but we've seen enough to know that it's happening inequitably. So this is just one example, and this is from North Carolina, but I can tell you the numbers are very similar in most states. Black people make up 22% of the population and 26% of the healthcare workforce in North Carolina, but only 11% of vaccine recipients. White people are 68% of the population, but conversely have been 82% of those vaccinated. So you can see we have disproportionate rates of who's getting vaccinated. So again, if we think about why that might be, it's certainly multifactorial, and there's probably numerous reasons, but I think the two broad biggest issues we need to be thinking about are access as well as mistrust. When we think about access, which we'll get to in a moment, we're talking about technology, where vaccines are being given, hours, flexibility, et cetera. And mistrust, we're going to talk about here on this slide. So let's look quickly at this study from the Kaiser Family Foundation that looked at, who is most essentially enthusiastic about getting the vaccine. And so it turns out older adults are actually, as a whole, the most enthusiastic group, if you're going to break it down by some demographic. But of course, this lumps in, people of all races and ethnicities. But if you're looking at by race, white adults, 53% are very enthusiastic to get the vaccine compared to only 42% of Hispanic adults and 35% of Black adults. So we see a relatively big gap here in terms of, vaccine hesitancy. And it's really important to understand that this, skepticism or hesitancy to get vaccines is something that is built into a larger kind of structure or trend of some mistrust among certain minority communities that has built up over years of lived experience. So I think it's really important to recognize that this mistrust is not unfounded. You saw in my prior slides that people experience discrimination and bias in the healthcare system all the time. And there's a lot of reasons they may think and feel justifiably that the healthcare system, the public health system, and other systems are not necessarily looking out for their well-being or their good. There's not an easy fix to this, unfortunately. I think it takes relationship building. It takes a lot of work, a lot of time, a lot of investment. And we'll talk a little bit about that in a moment. But it's important to understand before we try to fix this, to understand where it's coming from and that it's not trivial and it's not superficial and that it is really justified in many instances. So in addition to mistrust, I think access has been a big issue. So we know that a lot of the ways to make appointments has been online and through kind of complicated web portals that not everyone is able to navigate. So unless you have access to a computer or a smartphone and internet and the know-how to do that and the luxury of time, these are things that can be really, really challenging for someone who's older or someone who has low socioeconomic status or low tech literacy, which we know does disproportionately impact people of color. And also, what's your social network? Do you have children who have time and the ability to kind of do this for you? A lot of people who are getting appointments, it's because they had a family member who was able to sit on that computer and refresh until an appointment became available. If you don't have that, if you're socially isolated, if you're if you're somewhere where you just don't have access to that, that's going to be really, really challenging. so those are the obstacles, those are the problems. How do we approach this? And I think when we think about, if we want the vaccine rollout, and really, if, any healthcare, any interventions to address health disparities to work and to actually bring us equity, we have to think about it. The approach has to do more than just be equal. So when you think about equality, it's giving everyone the same thing, no matter what. But equity actually takes into account the disadvantages that people are coming to the situation with, and then tailoring the approach to center around those who maybe are the most disadvantaged, and making sure that everyone is getting what they need to reach the same level of health. And so I think it's really important that we have this framework and this mindset when we think about, for example, the vaccine distribution and rollout. We shouldn't be thinking, okay, we're going to have this internet platform that theoretically anyone could sign up for. Maybe that, that feels equal and fair. We should be thinking about, well, who are our most vulnerable? Who are our highest risk? What are the challenges they face? And let's put out a strategy that is going to center those people and focus on those people and make sure that they are getting the vaccines first, so that we make sure that everyone is going to end up in the same place. So just a few concluding thoughts about, what healthcare providers can do to be, addressing these health disparities in older adults. It's really important to understand the impact of racism. And I think we've made that kind of clear during this talk. When you're dealing with your patients, it's important to listen with empathy, to create safe spaces, to really understand the lived experiences of your patients, to support, strengthen, and enhance resilience. So don't just focus on the challenges people have faced, but on the amazing strength that they must have to have gotten to this point in their life, to overcome those challenges. And how do you harness that resilience? How do you empower people to kind of tap into that, to continue living their best life in their older age? It's important to celebrate culture, whatever that means to the patient, to be mindful of triggers. So there's certain things that your patient may have experienced in their life that could be very triggering, and that the healthcare system in general can be very triggering for prior traumas and stuff. So it's important to be mindful of those, and to just be aware of, what you're doing, what you're saying, and the impact that that might have on your patients. Referring to mental health services and support when needed, and to destigmatize those types of things for older adults who may feel hesitant to utilize those types of services. And then finally, thinking outside the clinic, outside the hospital, is that healthcare providers can really be advocates as well, because like I said, only so much is going to get done within the healthcare system unless we are able to also shift and change the structures, and the social determinants of health. Many of the health issues that our older patients face are not going to shift. Thinking a little more broadly to health policy and health systems, they can invest in upstream social determinants of health, track outcomes data in real time and adjust. So we need to be looking at how are we doing with regards to equity and disparities, and actually make real-time adjustments to try to address those shortcomings. They can put efforts into recruiting, retaining, and supporting a diverse healthcare workforce. There's lots of data supporting the fact that having a diverse set of physicians, nurses, pharmacists, social workers is good, not just for people of color, but good for everyone. We can educate and train the existing healthcare workforce to be more sensitive to all of these issues and to be anti-racist in their practices. And like the last OLLI presentation on age-friendly health systems, I think this is really important for all of us as we age, but also thinking outside the healthcare system to age-friendly communities. How can people thinking about health policy and health systems actually think about the ways we need to make changes in communities to enable people to age independently, and continue to live in their community independently as long as possible. And again, there's different considerations for people coming from different types of backgrounds and with different levels of disadvantage. And finally, again, advocate, because there's so much to be done, and all of us have to have our voices heard. So with that, that's the end of my remarks, and I'd love to open it up to questions.
Okay, thank you very much, Dr. Makaroun. This is Catherine Kidd, and I'm the person who's working with you to monitor questions. I'm not quite sure why my face isn't up there yet, but that's fine. We have lots of questions. I'd like to, I'm not going to take these in order because they sort of cluster a little bit. And one question is, what are some of the overlaps between race and gender in social determinants of health? And I know that you touched on some of those, but Barbara Vinier, who asked this question, was referring especially to the question of the emotional burdens of single parenthood, for example, as a factor in long-term health.
I see. Okay, I think I know. I think I understand what that question is. So again, this kind of gets to the intersectionality piece, where we see that each part of someone's identity and the way that living in the world and in your society as a member of that group definitely impacts your lived experience and your health. Certainly, and I didn't touch on this much in the talk, but certainly women of color, for example, experienced a whole host of challenges that men of color may not, and vice versa, actually. So we didn't talk about things like the school to prison pipeline for Black men, which has terrible consequences for communities and for health. But I do think so for women in particular, we know that, so I mentioned kind of stuff around maternal and prenatal mortality increasing for women of color, but there are also, we know that for women in general, this goes across races, that women tend to be more caretakers and do more caregiving duties, and that includes also parenting. And so there's certainly a lot of additional stressors that come along with caregiving while working potentially and having economic burdens. And so if we're thinking about, for example, more the older adult population, this is certainly something we see a lot, where women may carry a lot of the burden of caregiving and end up losing wages, losing work because of that. And that leads to kind of, we know that that older women tend to reach older adulthood with lower wealth, lower income, lower savings, lower economic stability because of that. Yeah, so I mean, certainly sex is another really important characteristic that does impact social determinants and health outcomes for older adults.
Okay, thank you very much. Another question is, given all of these factors of social determinants of health and with the change in the administration, do you see certain legislation coming up that affects healthcare and especially the social determinants of health? And could you point us towards some things that we should be supporting?
Great question. I wish there was just one piece of legislation that would address everything. So I think, as you saw on the slide where we went through, each of the kind of buckets that this falls into, it's a really diverse group of issues, right? So there's going to end up being actions and efforts and initiatives and laws that address education that are going to be different than what, addressing housing, that are going to be different than are addressing, transportation, et cetera. So I can't point you towards, one law that that's on the table that you should be calling your senator or congressman about right now, but more to just have your eyes open to these issues broadly and to always be voicing your support and your concerns to your legislatures. To me, if I were to pick one issue that I think needs the most attention, I think it's education. I think that our education system, and I am not an expert in education. I don't know the answer of how to fix it, but I just know that it does. I think that so many things fall downstream from education, that I think if we were to be able to fix one thing, high quality early childcare, early education, and opportunities for higher education would probably have a huge impact. I will say the new administration has already, it's very early, of course, but they've already put forth several initiatives that are focused on like the caregiving workforce. So that broadly encompasses, childcare, but also elder care. And I think that's another really important one because, again, thinking about the way, for example, that women are disproportionately taking on the burden of caregiving, and those jobs oftentimes are either unpaid if you're a family caregiver, or if you are a paid caregiver, it's part-time, there's no benefits, it's a really hard job. And I think that that's an area that needs a lot of help, and I think the Biden administration is actually attuned to that and has some plans to move that forward. So that's something I'm gonna be keeping my eye on for sure.
Okay, thank you very much. Although this factor is all the way over at the one end of the social determinants of health, have there been studies that point to positive effects of the Affordable Care Act with regard to access and possible long-term implications of increased access to healthcare?
Yeah, so there've definitely been studies that have shown, so one of the most important parts of the Affordable Care Act was Medicaid expansion, actually. And so there have been quite a few studies looking at the impacts of states that, but it was a choice, right? So states could choose to expand their Medicaid or not. Mm-hmm. And there have been quite a few studies that have shown that since the rollout of the Affordable Care Act, comparing states that chose to expand their Medicaid coverage versus not, and showing that improved preventative services and health outcomes in states that expanded their Medicaid, as well as increased use of more preventative health care, so like primary care visits, which are things that people may avoid if they don't have health insurance, et cetera. Maybe they would only utilize the emergency department like in an emergency. So yeah, there are actually there are data that support that those types of higher level health policies that do kind of try to strip away some of those economic barriers to accessing healthcare have made a difference. And certainly I think, more efforts in that arena are definitely worthwhile.
Okay, thank you. There were a number of questions related to your comments about attitudes of people who are being trained as physicians. And I'd like to broaden that also to include nurses and physical therapists and other allied health fields. What are some of the things that you think are being done best to address the myth of racism that continues to exist among students in medical school?
That's a really good question. And I think to answer it, I will just give a little more context, which is that, holding biased misperceptions or falsehoods, I think is reflective of the society in which these students were raised and kind of came of age, more so than an indictment of them personally, let's say. And I certainly would think that most people going into medicine are certainly not overtly racist, although all of us are impacted by racial bias and those of us who have certain privilege, right, like experience the world through the lens of white privilege. But medical training and what we learn in medical school continues, and this is only starting to unravel, now continues to teach things that are consistent with a biological basis of race difference theory. And one example of that has been called into question a lot recently is kidney function. So for example, even now, most places will calculate kidney function based on a blood level of something called creatinine. And the calculation that takes that into account is different for white people than for Black people. And that's based on, old studies and kind of beliefs that maybe Black people have higher muscle mass than white people. And again, like, we know this is not true. And so there's a lot of people now questioning, and a lot of studies coming out showing, well, actually doing this is disproportionately disadvantaging Black people, for example, from kidney transplant lists, because we're telling them that they have better kidney function than in fact they do. And so this curriculum that med students are being exposed to, which is not really a fault of their own per se, it's kind of the medical doctrine that has continued and is, we're starting to challenge and starting to unravel, subvertly, I think, also teaches that message that race is real and that there are biological differences. And so I think that now finally we're starting to talk about that more, we're starting to challenge that more. And certainly I think the overt curriculum is that, all of these things are really important. It is, trying to be more anti-racist all the time. But it's also important to address what we call like the hidden curriculum as well, or like what's happening with the more subtle messages. And then also with, like the formulas, the treatments, things like that.
Okay, thank you. We've had a number of questions with regard to the incredible fatality rate and infection rate during COVID in nursing homes.
Yeah.
And how do you see that connected to social determinants of health and attitudes towards aging?
So that's really, it's a two-pronged question. So I'll take it in two stabs. So it's absolutely true. So by some estimates, so it's about 113,000 of our 440,000 deaths in this country have been in nursing home residents. So it's over a quarter. Some estimates are actually up to 40% of the deaths in the US have been in nursing home residents. So it's really astronomical. And of course, we have to know and understand that there are, in this case, underlying conditions and predisposition to being sick. So if you're in a nursing home, you are likely older, more frail, and more sick than the average, older adult. So, but in addition to that, there are things, so when we think about those social determinants of health, you also have to think about, well, who is in a nursing home in the first place? A lot of people, if they have the resources or the ability to have care in their own home or pay for private caregivers or have a family who has the financial security and luxury to provide unpaid family support, they may not ever end up in a nursing home. Similarly, a lot of people actually, when COVID started, because visitation was not allowed, a lot of families who had the ability took their family members out of nursing homes. And again, those are probably the more privileged people who were able to do that. So I think you see definitely that there is this, in that regard, just the people who end up in nursing homes in the first place are likely to have experienced more social determinants detrimentally impacting their health to get them to that place in the first place where they end up in a nursing home, but also they had less resources to prevent them from having to go into the nursing home, even given those needs. The other thing, and this is the second part of the question where ageism comes in, is that I think, the conditions in nursing homes now, and this is not, it's been really challenging. So I'm not trying to criticize the efforts and the really hard work that everyone who works in nursing homes had done over the past year. It's been so hard. That said, the quality of care, I think, has often been questionable, and a lot of the circumstances have been really horrible for adults living in nursing homes right now, in terms of the social isolation, the loneliness, not being able to have visitors, even like the staff not being able to check in on them as much because of these issues, the understaffing because of so many staff getting sick. And, the ageism comes in just in terms of like being okay with it, right? Is that as a society kind of seeing these really horrific conditions for people and not having a mass public outcry, quite frankly, because, these are people that are in some ways, living in very inhumane circumstances at times, kind of being just trapped in a room without, human contact for long periods of time and stuff like that. So, and just, again, I think this is not just for people in nursing homes, but the way that COVID has impacted older adults predominantly. I mean, I think we all appreciate COVID as being very serious now, but when it first started happening, I think we did see a slowness to react that I think in part was because of who it was impacting, which was mostly older adults. And I think that is reflective of the way in which we do devalue older adults in this country. And I said this, during the interview I had earlier this week, but, if it was children who were, disproportionately dying, the response would have been very, very different. So it's, yeah.
Okay, thank you. We have a number of questions with regard to sort of the intersectionality issue. And that is, for example, if you break data out for low-income whites or for Native Americans or Pacific Islanders, are their health outcomes more similar to those of the African American community, or is race less a factor? So sort of where's the balance between race and class here?
Right. So they both matter independently. So low economic status will impact your health negatively. That being said, if you compare a Black person and a white person, both with the same socioeconomic status, the Black person's going to do worse. One of the clearest places you see that, actually, or maybe one of the most striking areas, if you look at the maternal mortality. So a Black woman with a PhD is still at higher risk of dying than a white woman without a high school education. So there are certain areas where race really just trumps the effect of socioeconomic status, but they're both really important, but they function independently of each other. So race is not a marker for socioeconomic status, which I think is kind of what that question might have been getting at.
Okay, and are there good studies with regard to the social determinants of health and Native American or Pacific Islander populations? You mentioned the differential impact on those communities for COVID, but could you speak more broadly to that?
Sure, a little bit, yeah. So in fact, if you look proportionally, Native American populations, Pacific Islander, are actually in many ways impacted the worst from many different kinds of health conditions, and including COVID. They've had incredibly high mortality rates and morbidity rates from COVID. There's also very high, burden of mental health issues and substance use disorders in these populations. So yeah, there are definitely studies on that, and it's definitely an extremely impacted group. I think the only reason it gets a little less attention is because of the size of that population, but it doesn't mean that it's any less important, and certainly deserves a lot of attention and deserves the same degree of consideration. And I think the same issues apply. But again, there's a different context there, right? So the experience, the type of racism that Native Americans will face is rooted in a very different history than that of Black Americans, even if the outcomes of that are similarly detrimental.
Okay, thank you. We have a number of questions with regard to vaccines and the issue of the hesitancy to um, accept the vaccines. We can't go back in history, unfortunately, but are there things that can be done now to increase the uptake for vaccines broadly in the community and specifically with groups that have higher risk factors?
Yeah, so there have been, so you know, I'm not an expert on this, but I've done a little bit of reading and um, about it. So some of the data I presented from Kaiser Family Foundation, they've also done, asked people about kind of what influences them in terms of, willingness to get the vaccine. And it does seem that, personal relationships are really important, whether that's, a family or friend who got the vaccine and then shared their experience with you, or whether it's a healthcare provider that you really trust who takes the time to explain it to you. We also know that racial concordance of like a doctor and the patient, or, it doesn't have to be a doctor, but someone in an authority figure who is kind of encouraging this. So maybe it's a religious leader, a minister, or, a teacher at school, or, lots of different settings, that can also be important and help. So to me, I think the approach probably needs to be a little more community based, a little bit more rooted in relationships, because that's where people do have trust, right? Like, we don't trust big government, or we don't trust, like, the scientists writ large that we don't really know, or we don't understand the science, and they don't really have my back anyways. But kind of a more public health approach that's rooted in community outreach, through networks that people do trust, and using language that people understand, showing them that actually so you can't just say we want you to get the vaccine and then make it impossible to get the vaccine, right? Because that's like a mixed message. So the other thing is we have to fix the access problem, so that we're really showing people in these higher risk groups and in these vulnerable communities that we're not just saying it, but we are showing it with our actions. And so I think that fixing the access issue, making it easier, making it accessible, making it low tech, is really important. And then coupling that with messages from people that are trusted, and in language that is relatable, and with also using stories. I think stories always help more than, data, for the masses. So yeah, those would be my kind of layperson's thoughts on that, given the reading I've done.
Okay, thank you very much. We have a number of questions related to age-friendly health systems and how older people can be better advocates for themselves for getting health care that really deals with the whole range of health determinants.
Mhm.
And so does the University of Pittsburgh medical system, are they part of the age-friendly health system? And how could we become better advocates for the 4Ms of age-friendly health systems as patients?
Yeah, so I mean, I think like the social determinants are distinct, but certainly related to the 4Ms or the 5Ms, and to age-friendly health systems. Social determinants certainly affect one's ability to age independently in the community, to continue to have good mentation, to you know have the know-how to kind of express advanced care wishes, things like that. So they're certainly related. I think that in terms of how, older patients can advocate for themselves in the healthcare setting, I think this was touched on in the last session with Dr. Brennan. Talking to your provider about the things that are important to you is really important. And actually, bringing up those things and talking about it is really important. So, if there's something, recognizing that there are certain limits within the healthcare system of what can be addressed that are, under the umbrellas of other like social service system. What I mean by that is, in an ideal world, we would work seamlessly in a system that is kind of tied to the other, we would have maybe more like currently we have a hub and spoke model where the hub is the healthcare system or the doctor's office or whatever. And we have all these other things on the periphery that, maybe your area agency on aging and social services and maybe like the food bank and transportation services and education, they're kind of on the periphery, and we think of the healthcare system as the hub. And maybe based on what I showed you in this talk, I could convince you that maybe the healthcare system shouldn't be the hub of health. And that maybe there should be something else in the center. Maybe it should be a different shape altogether. But that calling to your doctor's but most doctors are still very medical centric. And so if you happen to have a doctor who doesn't maybe think this way or doesn't maybe appreciate those issues, I think though that most people are very open to trying to consider those things and address them for you, or at least refer you to the right resources and places if they themselves don't have those resources to address it for you. Yeah, I mean, I personally, so my research is I study elder abuse, and that's kind of where my academic focus is. And actually, I do a lot of work, and I think there's a lot of power in patient empowerment and kind of not always relying on the doctor to get it right, or not always relying on the healthcare system to get it right, because I'm going to tell you, we're just going to get it wrong a lot of the time. And actually teaching patients about how they can help their doctor get it right more, or how them knowing more about the things that are important can actually really make that relationship work a lot better. Yeah, because unfortunately, at least at this point, we still have a long way to go in terms of kind of educating the general healthcare workforce in terms of geriatric principles and the 5 M's and all of that.
Okay, we have about 2 minutes left in our time. So rather than try to squeeze in one more question, just want to say people have loved this talk. There are lots of positive comments and lots of people asking if they will have access to the slides after the talk. So just to remind to everyone that you will be getting a link tomorrow from the OLLI office that will give you access to the recording of the talk. So please look for that. Also, we have another talk coming up in March with Louise Aronson, the author of Elderhood, and who I believe was one of Dr. Makaroun's mentors. So please watch the OLLI website for that, and be trying to catch the announcement of that. That will also be free and open to the public. So Dr. Makaroun, I wish we could have you for longer, or we won't invite you back, but this has been great.
Well, thank you so much for having me, and thanks for all the engagement and all the great questions. Sorry we didn't have time to get to all of them, but I encourage everyone to attend Dr. Aronson's talk. I'm sure it will be much superior to mine, and you can ask many of similar questions to her. She's certainly an expert in ageism, and I learned a lot of what I know from her. So I definitely encourage everyone who maybe didn't get a question answered to attend that talk and hopefully shoot it her way as well.
Okay, thank you. And thanks to everyone who attended today. And we look forward to having you join us for future OLLI talks. Thank you so much.